Hi everyone, and welcome to our module on the menstrual cycle. By way of review, the female reproductive system involves the hypothalamus releasing GnRH onto the pituitary gland, which when stimulated will secrete LH and FSH, which can then go and interact with the ovaries. The ovaries then produce estrogens like estradiol. They can also produce progesterone, and they can also produce inhibin, all of which can feed back on the hypothalamus and the pituitary. And in this module, we're going to talk about how this whole system works to create the menstrual cycle. The menstrual cycle involves a cycle of changes that occur in the ovaries and the uterus about every 28 days in response to hormonal changes in women of reproductive age. And we'll start by talking about the changes that occur in the ovaries during the menstrual cycle. And to do this, we first need to review some basic principles of the ovaries. So the ovaries contain follicles. These are the functional units of the ovaries. They are a spherical collection of cells that contain a single oocyte or egg. In each menstrual cycle, one follicle in the ovary will mature and release its egg, and when it releases its egg, that's called ovulation. This is a drawing of an ovarian follicle shown on the screen. It is an egg surrounded by cells. This is the oocyte or egg in the center. It's surrounded by some fluid, which is called the antrum of the follicle. It's also surrounded by two layers of cells. The granulosa cells are the innermost layer, and the theca cells are the outermost layer. And it is the theca and granulosa cells which are going to synthesize estrogens, which drive the growth of the follicle. Women are born with thousands and thousands of follicles in their ovaries, and when they reach puberty each menstrual cycle, some of those follicles begin to mature. As shown in this picture, a number of primordial follicles will begin to mature, but only one of those will end up being selected and will become the dominant follicle. This is the follicle that will release its egg. The other follicles will undergo atresia, and therefore each menstrual cycle, several of the primordial follicles mature, one releases its egg, and the others die. The menstrual cycle in the ovaries has three basic phases. The first is called the follicular phase. It gets its name because this is the phase when the follicles grow. Then there is ovulation and release of the egg, and following ovulation there is the luteal phase where the ovary produces progesterone to help prepare the uterus for possible pregnancy. Shown on this slide is a classic picture illustrating the changes in hormone levels during the menstrual cycle. The menstrual cycle begins on day 0, shown here. On this graph, you see the changes in the levels of FSH and LH. Both levels are initially low. They spike right before ovulation, and they fall again after ovulation. On this graph is shown the changes in the levels of estrogen and progesterone. Estrogen levels spike just before ovulation and then fall after ovulation. Following ovulation, there is a gentle rise in the estrogen level and a much greater rise in the progesterone level. And we'll talk about why all of these hormonal changes occur in the next few slides. At the top of this slide is a picture of what's going on at the follicular level inside the ovary. The follicular phase is the first half of the menstrual cycle. This is where the follicles are developing, and we're going to talk about that phase on the next few slides. In the follicular phase in the ovaries, follicular growth is driven by changes in hormone levels. At the level of the hypothalamus, during the follicular phase, there's an increase in the GnRH pulse frequency that is stimulating the pituitary gland. This leads to a rise in FSH secretion from the pituitary, which drives estradiol production from the ovaries. And the high levels of estradiol leads to recruitment of follicles. The estradiol also feeds back negatively on the pituitary and suppresses FSH and LH release. Eventually, the estradiol leads to selection of one dominant or ovulatory follicle that will release its egg, and this takes about 10 to 14 days to occur. It varies in length, and this is the reason that women have variable menstrual cycles. It's because this portion of the menstrual cycle varies from 10 to 14 days. If we go back to this slide, you can see this gentle rise in the FSH level here, which stimulates an increase in estrogen production, and that's what's happening in the follicular phase. Eventually, this high estrogen level is going to lead to ovulation. Ovulation occurs due to something called the mid-cycle surge. When estrogen levels get high enough, there is a switch from negative feedback of estrogen to positive feedback. Estradiol will trigger an increased frequency of GnRH pulses, and this will lead to a surge in the level of LH coming from the pituitary gland. And an oocyte will be released from the dominant follicle about 36 hours after the LH surge. And this mid-cycle surge is the basis for ovulation testing that women can use when they're trying to get pregnant. You can purchase an ovulation testing kit like I've shown on the screen here at a drugstore. Women can test their urine, and the kit will show when there is the presence of LH in the urine, and this means that they are about to ovulate and they're at the right time to get pregnant. If we go back to this slide, when the estrogen level gets high enough, it triggers this LH surge shown on the screen here, and that is what triggers ovulation. There is a phenomenon called Mittelschmerz in which women develop abdominal pain around the time of ovulation. This presents as mid-menstrual cycle abdominal pain, and the pain is due to enlargement of a follicle, or sometimes it's from follicular rupture with bleeding. It usually presents as mild unilateral abdominal pain. It's unilateral because it's on the side in which the ovary is enlarged or ruptured. The pain usually resolves in a few hours or days. This is generally a benign disorder. However, sometimes it can mimic other disorders and be confused with appendicitis. After ovulation, the menstrual cycle enters the luteal phase. This phase is driven by a structure in the ovaries called the corpus luteum. The corpus luteum is a temporary endocrine gland that is formed from the follicle that released its egg. The job of the corpus luteum is to produce large amounts of the hormone progesterone, which will prepare the uterus for implantation and pregnancy. There's also some estradiol released by the corpus luteum. The progesterone and estradiol released by the corpus luteum feed back on the pituitary negatively so that the levels of LH and FSH fall. Going back to this slide, this is the luteal phase, the second half of the menstrual cycle where the corpus luteum forms. It produces large amounts of progesterone as indicated by this spike in progesterone levels here. There's also some estrogens produced from the corpus luteum, and the estrogen and progesterone levels cause the LH and FSH levels to be very low in the luteal phase. Eventually, the corpus luteum degrades, and this leads to a fall in the progesterone levels, and this triggers menstruation in the uterus. We'll talk about that in a few slides. And menstruation always occurs 14 days after ovulation. The luteal phase of the menstrual cycle is constant in length. Now, if fertilization occurs, the embryo will begin making human chorionic gonadotropin, or HCG. This will maintain the corpus luteum and maintain progesterone production. This will keep the levels of LH and FSH low so that the menstrual cycle does not start all over again in the setting of pregnancy. So back to this slide a final time, when the progesterone level drops here, that is what triggers menstruation, and that begins another menstrual cycle. If, however, implantation occurs, HCG will maintain the corpus luteum so that the progesterone level remains high and so that LH and FSH levels remain suppressed. So everything I've talked about up to this point are the changes in the ovaries during the menstrual cycle. Now I'm going to talk about the changes in the uterus during the menstrual cycle. This is sometimes referred to as the uterine cycle. These are changes in the endometrium, which is the endothelial layer of the uterus that sits on top of the myometrium, which is a smooth muscle layer. The uterine cycle is driven by estrogens and progesterone, and it parallels the ovarian cycle, and it has two phases. The proliferative phase is analogous to the follicular phase of the ovary. It occurs prior to ovulation. The secretory phase is analogous to the luteal phase of the ovary. This occurs after ovulation. The proliferative phase of the uterine cycle begins after menstruation. Menstruation is followed by endometrial proliferation. This is stimulated by estrogen. The endometrial thickness increases. It can get more than 10 times thick over the course of the proliferative phase. There is growth of the glands, the stroma, and the blood vessels inside of the endometrium. If we go back to this slide, I told you how estrogen levels rise during the follicular phase of the menstrual cycle. That rise in estrogen levels stimulates the uterus, and that drives the proliferative phase of the uterine cycle. After ovulation, the uterus enters the secretory phase. This phase is driven by progesterone. Progesterone's job is to inhibit proliferation of the endometrium and prepare for implantation. In this phase, the uterus no longer wants the endometrium to grow in size. It wants it to be ready for the embryo. So there are numerous secretions that are released in the uterus to get ready for the embryo. And there are also very important changes in the blood vessels that are driven by progesterone. The vessels of the uterus grow and coil, and they form structures called spiral arteries about 9 days after ovulation. And these arteries are critical for implantation and support of the fertilized egg. If implantation does not occur, the woman will menstruate. This happens when progesterone levels fall. There's vasoconstriction of the spiral arteries, and then there is apoptosis of endometrial cells, which occurs. It used to be believed that vasoconstriction and ischemia drove menstruation. It's now believed that apoptosis is actually the cause. But through whatever mechanism, there is collapse and desquamation of the endometrium, and this leads to menstruation. On this slide, I've shown the uterine cycle on top along with the hormonal changes on the bottom. During the follicular phase of the menstrual cycle, as the estrogen level is climbing, the endometrium is increasing in thickness. This is called the proliferative phase. After ovulation, progesterone levels are high, as shown in this picture down at the bottom. During this phase of the menstrual cycle, the uterus has entered the secretory phase. The endometrium is not increasing in size, but you can see the development of the spiral arteries as indicated by these squiggly lines here. For the remainder of this module, I'm going to talk about causes of amenorrhea, or failure to menstruate. And there are many, many causes of amenorrhea, but what I'm going to focus on are the ones that are related to abnormal levels of the female reproductive hormones. First, we need to define a few terms. Primary amenorrhea is failure of menses at puberty, and this is usually due to an anatomic or genetic abnormality. What is much more common, especially in adult medicine, is secondary amenorrhea. This is cessation of normal menses after prior normal periods. When a woman presents for evaluation of secondary amenorrhea, there are a number of groups of causes you need to consider. First of all, pregnancy is the most common cause, and that needs to be ruled out right away with a pregnancy test. Then there are a number of causes related to the hypothalamus, the pituitary gland, and other hormones like prolactin, thyroid hormone, and cortisol that you need to consider. We'll talk about those in a minute. In terms of the ovary, for normal menses, two things have to occur. During the follicular phase, the ovary needs to produce estrogen, which will proliferate the endometrium. Then ovulation needs to occur, and the corpus luteum needs to make progesterone, whose levels will rise and fall, and these will together cause normal menses. So if there's a problem with estrogen production or progesterone production, these can lead to secondary amenorrhea. There's an older test for causes of secondary amenorrhea that's not done much anymore. It's called the Progestin Challenge. This test isn't used much in the modern era because it has lots of false positives. This test involved administration of a progestin compound like the kinds that are found in birth control pills, either orally or intramuscularly, and then observation of menstrual bleeding would be done for about 7 days. If bleeding occurs after a progestin challenge, this indicates that estrogen is present but not progesterone. Recall that estrogen makes the endometrium proliferate, but then you need the typical rise and fall in progesterone for menses to occur. If menses do occur after exogenous progesterone administration, it suggests that progesterone is absent, and this can occur when there's anovulation. The woman is not ovulating, so the corpus luteum is not forming to make progesterone. And the classic cause of this scenario is polycystic ovarian syndrome, which we'll talk about later in this module. If no bleeding occurs following a progestin challenge, it suggests one of two things. Either there is no estrogen to proliferate the endometrium and prepare it for menses, or there is an anatomic menstrual outflow problem. You can follow up a progestin challenge that results in no bleeding with an estrogen progestin challenge to see if menses occur after both estrogen and progesterone are administered together. And the common cause of this second scenario, where there is no bleeding after a progestin challenge, is menopause, where both estrogen and ovulation and progesterone are all absent together. We'll talk about menopause later in this module as well. The first cause of amenorrhea I'm going to discuss is Mullerian dysgenesis. This is a cause of primary amenorrhea, or failure for menses to begin at puberty. And this condition is caused by failure of the Mullerian duct to develop normally, and as a result there is an absent upper vagina and or uterus. In this condition, the ovaries are entirely normal, the estrogen and progesterone levels are normal, and the LH and FSH levels are normal. So if you see this in the board question, you need to recognize that because all these hormone levels are entirely normal, the pituitary gland, the hypothalamus, and the ovaries must be normal. The problem must lie elsewhere, and that problem lies in the absence of the uterus, so there is no lining to be shed at menses. Now let's talk about causes of secondary amenorrhea. As I said before, the most common cause is pregnancy, so this always needs to be excluded in a workup for amenorrhea. You screen with a serum or urine HCG measurement. You can also develop amenorrhea in the setting of thyroid disease. Both hypo and hyperthyroidism can cause secondary amenorrhea. A prolactinoma can cause amenorrhea. Prolactin inhibits GnRH release and will lower the LH and FSH levels. I talk about this in more detail in the module on pituitary disease. And then finally, Cushing's syndrome can also cause amenorrhea from high cortisol levels. I talk about this in more detail in the modules on the adrenal gland. Another cause of secondary amenorrhea is very low body weight. This is called functional hypothalamic hypoamenorrhea. It's believed that stress and cortisol levels plus low caloric intake lead to low GnRH levels, which leads to low LH and FSH level. It's important that you know that the problem is as high up as the hypothalamus. The GnRH level will be low, and this problem improves when women are administered pulsatile GnRH, indicating that the problem begins in the hypothalamus. And this is classically seen in women who are anorexic. They have very low body weights, they have high levels of stress hormones, and this all leads to functional hypothalamic amenorrhea. Another cause of amenorrhea is menopause. This is the permanent cessation of menstrual periods caused by depletion of ovarian follicles. Women are born with a certain number of ovarian follicles, and eventually they run out, and this is when menopause occurs. The median age of onset is 51 years. It is usually preceded by several years of abnormal periods, and from the perspective of the female reproductive hormones, the woman loses estrogens and progesterone coming from the ovaries in this condition. More specifically, the woman loses estradiol production from the ovaries. The theca and granulosa cells are no longer producing estradiol. This does not, however, mean that there is a complete lack of estrogens. The source of estrogen after menopause becomes adipose tissue. Recall that adipose tissue has the enzyme aromatase, and it can convert androgens like androstenedione into estrone. If we look at the bottom of the screen, on the left side is the structure of androstenedione, which is a weak androgen. It is produced from the adrenal glands. Aromatase can convert that into estrone. What aromatase does is it removes this carbon here and converts this ring into a ring with 3 double bonds. When you do that to androstenedione, you get a molecule of estrone. In addition to losing estradiol from the ovaries, women lose inhibin production from the follicles, and inhibin normally suppresses FSH release, so you will see a high FSH in women who are menopausal, and an increase in the FSH level is an early finding in women approaching menopause that you can see on biochemical testing. Eventually, both the FSH and the LH levels will become elevated, but FSH occurs earlier and is the more sensitive biochemical test. The classic symptom of menopause is the presence of hot flashes. These are subjective sensations of warmth that women experience around menopause. They usually come on quickly, last a few minutes, and then pass. They are associated with the drop in estrogen levels seen during menopause, and they can be treated with hormone replacement therapy, which we'll talk about in a minute. Another symptom of menopause is vaginal atrophy. The vagina can become thin, dry, and friable, and this is from loss of estrogen stimulation. Osteoporosis develops in women who are postmenopausal. This is bone loss from lack of estrogen. And then finally, there is an increased risk of cardiovascular disease, including heart attack and stroke. The risk rises after menopause. It's thought to be due in part due to estrogen deficiency, although it's not completely understood why this occurs. Hormone replacement therapy can be used to treat the symptoms of menopause. This is usually done with an oral or transdermal version of estradiol. In women who have an intact uterus, a progestin component is added. This is a drug that is similar to progesterone, the same type of drugs that are used in birth control pills. Many women who are postmenopausal have had a hysterectomy for uterine fibroids or some other indication. Among those women, hormone replacement therapy can be done with just an estrogen component. However, if women have an intact uterus, a progestin needs to be added to prevent unopposed estrogen, which would cause endometrial hyperplasia and is a risk factor for uterine cancer. The main benefit of hormone replacement therapy is that it relieves hot flashes, and this is the main indication for using hormone replacement therapy. It also improves bone density. There are possible risks. It likely increases the risk of DVT, stroke, and MI. It also increases the risk of breast cancer. It used to be thought that hormone replacement therapy lowered the risk of cardiovascular disease, and for this reason, many women who are postmenopausal were administered hormone replacement therapy not just to treat the menopause symptoms, but in the belief that it would lower their risk of cardiovascular disease. Recent large clinical trials have shown that these drugs probably increase the risk of stroke and MI, and for this reason, the only time hormone replacement therapy is usually used anymore is to relieve hot flashes in women who are highly symptomatic. The final cause of amenorrhea I'll discuss is the polycystic ovarian syndrome, which is a common cause of secondary amenorrhea. This disorder is very complex and it's incompletely understood, but it's believed that a woman's genetics plus environmental factors like her diet, which can lead to obesity, raises the ratio of LH relative to FSH in the serum. The LH drives production of androstenedione from theca cells, and androstenedione, as you may know, is an androgen. It will be released into the serum, where some of it will be converted into estrone by adipose tissue like we talked about previously. The estrone then further suppresses the FSH level, and this leads to anovulation. In reality, PCOS is much more complicated than the concept map I've shown you on the screen, but I'm going to try to give you a way you can think about it to keep the clinical and laboratory features straight in your mind. So PCOS begins with a combination of a woman's genetics plus environmental factors like her diet, which can lead to obesity. This leads to two key features of the disorder. First is hyperinsulinemia, which we'll talk about in a minute, and second is an increased ratio of LH relative to FSH. The LH drives the production of androstenedione from theca cells. Now normally that androstenedione would be converted into estradiol by granulosa cells, but because the level of FSH is low, this does not occur. This means that the androstenedione begins to circulate where some of it is converted to testosterone, and this leads to elevated levels of androgens in general, which causes hirsutism and acne, which are two of the key clinical features of the disorder. Now, some of that androstenedione is converted to estrone in adipose tissue. Estrone feeds back on the pituitary and further suppresses the FSH production. Because there is low FSH production, there is no ovulation. In addition, follicular cysts will develop, and this will all lead to a low level of progesterone because the woman is not ovulating normally. I mentioned this before, but PCOS is associated with hyperinsulinemia. PCOS is associated with insulin resistance, and as a result, the woman's insulin level needs to rise in order to maintain normal blood sugar levels. Now, you may know that obesity is also associated with hyperinsulinemia, but the hyperinsulinemia seen in PCOS is more than expected for the degree of obesity seen in these women, and this can lead to diabetes. How this ties in with the hormonal abnormalities is not well understood. I've always thought of it as a side issue to the hormonal problems. So in this slide, I've summarized the clinical features, all of which were indicated on the last slide. This classically occurs in obese females. They developed hirsutism, which will present as facial hair. There is acne. They will have amenorrhea, and they are infertile. And on ultrasound, you will see multiple follicular cysts. These are follicles that fail to develop normally, and this is how the disorder gets its name, polycystic ovarian syndrome. This disorder is usually diagnosed clinically. It's usually fairly obvious when you meet an obese woman who has hirsutism and acne. You can measure the total testosterone level. Studies have been done where various hormones have been measured, and the total testosterone turns out to be the most reliable indicator. If you measure the LH and FSH level, they may be within normal range, but remember the LH to FSH ratio will always be abnormal. It's usually greater than 2 to 1 or 3 to 1, and this is a characteristic feature of this disorder, and it's because the LH and FSH levels are out of balance that you get the production of so many androgens. There are a number of ways to treat this condition. First of all, weight loss will help. The women who have PCOS are obese, and if they lose weight, the syndrome gets better. Oral contraceptives are the mainstay of therapy for women who are not trying to get pregnant. This will suppress the LH release and improve the hormonal imbalance. In addition, the estrogen component of the contraceptives will increase the amount of sex hormone binding globulin, and this will pull free androgens from the plasma and decrease the effects of excess androgens. Spironolactone can also be used. Spironolactone is a potassium-sparing diuretic, but it blocks the effect of androgens. And then finally, there are two diabetes drugs that improve insulin resistance, metformin and TZDs. It used to be thought that these might be useful prophylactically in women with PCOS who had not yet developed diabetes. The clinical trials were disappointing, so these drugs are not routinely used unless the woman develops diabetes, but you should be aware that these two classes of drugs improve insulin resistance, and insulin resistance is a major problem in PCOS. So that's a nice segue into some of the complications of PCOS, and the main one you should know about is the risk of diabetes. About 10% of women with PCOS develop diabetes by 40 years old. As I told you before, there is hyperinsulinemia and insulin resistance as characteristic features of the disorder. Another clinical finding you can see is acanthosis nigricans. These are plaques of darkened skin. They are associated with insulin resistance, and they are common in diabetes as well as PCOS. You can also see them in gastric cancer. And then finally, there is a risk of endometrial cancer. There is unopposed estrogens in this disorder. Women are not making progesterone, but they are making estrogens from their adipose tissue. This can drive endometrial hyperplasia, and this increases the risk for endometrial carcinoma. For my final slide, let me show you this algorithm for working up secondary amenorrhea. There are lots of algorithms like this. This is just one example, but you begin by ruling out pregnancy, which is the most common cause. You then rule out rare causes like thyroid disease, Cushing's disease, or prolactinoma, and you screen the woman for anorexia. Once all of these things have been ruled out, the FSH level becomes very important. The FSH level will be low in PCOS, or if it is normal, there will be a high ratio of LH to FSH. The FSH level is high, conversely, in menopause, and then you see a normal FSH level in Müllerian dysgenesis or some anatomic problem with uterine outflow and menses. And that concludes our module on the menstrual cycle.